Hello, everyone, and on behalf of Greendale Physical Therapy, I would like to thank you for attending today's lecture. I'm Alexandra Stetch. I'm one of the physical therapist assistants that works at the company, and I'm also the event coordinator. I'm here to introduce the reason for your attendance. Dr. Kevin DiSilvestro went to Harvard undergrad, where he played water polo and met his wife. He then went to medical school at the University of Maryland, performed his residency at Brown, and his spine fellowship at the Hospital for Special Surgery in New York City. He now works at St. Vincent's in Worcester, and he lives in Needham with his wife, who is a gyno-oncologist.
Yeah,
That's awesome.
gynecologic. That's good.
And at Tufts, and he has two daughters. And now, with no further ado, the reason for your attendance, Dr. Kevin DiSilvestro.
Hey, good morning, everyone. Thanks so much for taking some time out of your Saturday morning to come and listen to me talk, or even just get the coffee and donuts. So I'm just going to talk to you a little bit about today about some of the stuff that I treat in the spine, and how I do it. Okay. So I have no formal financial disclosures, but I do have to disclose I'm a huge Philadelphia sports teams fan. That was my whole extended family watching the Super Bowl this year, so I had a lot of fun doing that. And then I do have two daughters, ages 2 and under. So if I fall asleep in the middle of the talk, please just wake me back up. Last night was a little rough. Both of them alternating who was crying, but wouldn't trade it for the world. So just a little bit of an overview of what we're going to talk about. So first I'll start talking about the cervical spine or the neck, and then I'll transition down into the lumbar spine or lower back, and then focus a little bit on physical therapy's role in the management of these issues as well. Okay. So starting with the cervical spine and some of the things that can go wrong in the neck. So the most important thing that I think about when I'm thinking about the neck is something called myelopathy, and that's pressure on the spinal cord itself. So if we look at this image on the right here, these boxes here are the bones. The stripes in between are the discs. This is the spinal cord coming through, and you want to see white fluid all around it. But you can see there's a lot of pressure on the spinal cord, and this can present with usually some pretty consistent symptoms. So difficulty with fine motor skills. So if a patient notices that they're suddenly having difficulty buttoning their shirt or putting on jewelry, hand clumsiness. If you notice that you're just dropping things a little bit more frequently. Sometimes you get numbness and tingling more so in the hands, but kind of in the upper extremities. And then also you feel like your balance is off a little bit. So on exam, you might pick up on some weakness that's not always present. Usually they have increased reflexes. So below the level of where the cord is getting pinched, their legs might be jumping off the table when you tap them with the hammer. And then there's a couple of other special reflexes that I would test for that would be abnormal or show signs of pressure on the spinal cord. They might have difficulty with rapid alternating movement. So if you ask someone to open and close their hands really quickly and they're really struggling to coordinate doing that, all of those things are kind of pointing to potentially causing there's some pressure on the cord. There might be some numbness in the hands. And the other thing I'll do is have someone walk with their one foot directly in front of their other in a straight line. And if they really struggle to do that, that again is showing some difficulty with gait. What we know about this disease is that if you ignore it, it progresses in a stepwise fashion. So over time, you'll just kind of continue to have worsening and worsening of the symptoms. So the primary goal of surgery for this is to just stop the symptoms from getting worse, with the secondary goal of usually you can get recovery of what's been going on. Also knowing that if you catch it earlier on, you have a better chance at getting rid of those symptoms as opposed to in a case that's progressed really far. So the kind of the extreme example, I had one patient who was a 38-year-old construction worker who had basically an MRI looking like that, progressed to the point that he showed up in my office in a wheelchair and he couldn't use his hands to put a nut and a bolt together, which is kind of the extreme end of it. Fortunately, he's doing really well and recovered a lot of his hand function, and he's walking without assistive devices. So, this is probably one of the most important things that I can take care of in terms of impacting a patient's quality of life. The other thing that can happen in the neck is radiculopathy, or pressure on one of the nerves. So again, the image isn't showing up too perfectly, but on this one, we're slicing the patient up from left to right. The boxes are the bones, the stripes are the discs, and there's a disc herniation here. And here is where the nerves exit out to the front. And you can see this disc herniation here is putting pressure on that nerve. So that can cause either pain shooting down an arm, weakness in the distribution that matches that nerve, or kind of some numbness and tingling. So treatment for this. So normally for this one, you start with far more conservative measures. I try to be very conservative with everything I treat, myelopathy kind of being one of the few exceptions. But so for radiculopathy, you start with physical therapy. A lot of times patients will get better with some targeted physical therapy, and disc herniations can resorb over time. There's different oral medications that you can try to kind of help with some of their symptoms and the pain. And the other thing is targeted steroid injections to help cool off that nerve. And if they fail all of those conservative measures, or if there's progressive weakness, then that's when you'd consider surgery to go in and take the pressure off of that nerve root. So in terms of the cervical surgeries that I can do, one of the most common ones and kind of the gold standard is ACDF, or anterior cervical discectomy and fusion, which is just a fancy way of saying we're basically taking these two bones, removing the disc in between them, and then putting in some hardware in between to fuse them or turn them into one bone so that they heal together. And in doing that, you're then able to take all of the pressure off of either the central cord or the nerve roots as they exit. I think a relatively newer and kind of more exciting option is also a cervical disc replacement. So you do the same technique in terms of going in and removing all of the disc material to open up the space for the cord and the nerve roots. But instead of fusing those two bones together to become one, you put in an implant that allows for retained motion at that level, with the theoretical benefit of, if you're not removing motion from this level, you're protecting the levels above and below, so they're not seeing more force over time. If somebody has a bunch of different levels that are affected, then another really great option is a laminoplasty. So that's where I come in from the back of the neck. Most of the things are done from the front, but this one we come in from the back. And if you picture, this is essentially a tube around the spinal cord. And so you have bone surrounding your spinal cord. And if we were to cut on both sides and hinge that tube open, we can create a whole lot more space for the spinal cord as it's coming through. And you're able to do that at multiple levels across the whole back of the neck. And what's also great about this is I'm not fusing anything together. So I'm able to decompress like 4+ levels without having to take away any motion. And greatly increase the space available for the spinal cord. And then kind of one of the final options is if there's just one specific nerve root that's getting pinched. So let's say somebody has a disc herniation just impacting one nerve, and it's only really coming out to the side, it's not hitting the cord in the front. I can actually just come in from the back and open up that window where that nerve is coming out to create more space and let that nerve become happy again. And this one's great because it's something I can do through a tube. So when I do that, I make a small incision, so it's about 2 centimeters or less, and then I use dilators to just push the muscle out of the way, and I hold it back with the tube, and then I'm able to look through that tube with the microscope and move it around to look at whatever it is I need to look at with the spine. And then there's specific instruments. So when you're doing open surgery, everything's in line. But because I'm trying to look around my hands down through this tube, we have these special instruments that have the curve so I can see exactly what I'm doing. And then when I'm done, you simply just pull the tube out and all of that muscle falls back into place and closes up that dead space that you otherwise normally would have with open surgery. And that tube is held in place with a rigid arm. So it's a pretty neat way to do spine surgery with less insult to the soft tissues around the spine. So now moving on to the lumbar spine, or the lower back. So things that can go wrong in the lower spine, one of the first ones that I think about is neurogenic claudication. That's essentially, so up here is normal. You have the bone and disc in the front, a bony arch in the back. All those little dots in the middle are the nerves coming through, and then the white fluid all around. And you want to see lots of white fluid all around. And this is getting, now the bone and ligament back here is overgrown and starting to put more pressure on, and continues to put even more pressure. And then at the most severe, form of this disease, there's almost none of that white fluid left. So all those nerves are getting totally squished together. So this typically presents as somebody gets up, and if they walk, 20 yards, 100 yards, they get achy, crampy pain all over their legs. They have to stop and sit down, and it pretty much feels better right away. They'll feel better if they're bending forward over like a shopping cart or a walker, because that's helping to try to open up some of the space for the nerves in the back. The other thing that can happen is similar to the neck, you can get radiculopathy or pressure on a nerve in the lumbar spine. So again, similarly, you can have pain kind of shooting down the leg. You can have weakness in the distribution that nerve impacts, or numbness. And the nerves, just as in the neck, the nerves are pretty predictable in terms of what part of your leg is affected. So usually you want to make sure that what a patient is complaining about is matching up with what their imaging is when you're trying to figure out what to target. So there's two main areas that you can get pressure on the nerve. So you can either get pressure on the nerve where it's coming out to the side, the foramen, or kind of the window where that nerve is exiting between, or you can get it in the middle. So similar to that one I showed you before, but the nerves, before they exit out to the side, are traveling down here underneath this bony prominence. And if this overgrows too much, it can also put pressure on those nerves. So in terms of surgeries for the lumbar spine, so this is probably the most common surgery that I do. So it's a minimally invasive lumbar decompression or discectomy. And so it's the same concept with the tube. I make a 2-centimeter incision, just gently push the muscle out of the way and hold it back with a tube. And then I'm able to look directly at the spine, and I can remove the overgrown bone and ligament that's putting pressure on any of the nerves there. And what's really great about this is I'm able to I can rotate the bed and rotate the tube to then look over to the other side. So I'm able to completely decompress the lumbar spine all through a 2-centimeter incision, and adequately take the pressure off of both sides with just only coming down on one side. The other type of surgery that I commonly will do in the lumbar spine is a fusion, or a minimally invasive TLIF. And so I try to avoid fusions in general. Part of the minimally invasive approach is, one, avoid surgery if possible. You can't do less surgery than no surgery. And then two, if I'm doing surgery, I try to do the least amount. But there are certain times where you have to do a fusion because it's either the only way to get pressure off the nerve. So if the nerve is pinched where it's exiting here, because these two bones have collapsed on each other, then the only real way to open that back up is to restore the height with an implant in the front to recreate what it should look like with a healthy disc, and also removing an excessive amount of bone in the back that would destabilize things. So those are kind of the two reasons why I might have to do a fusion in this. But what's great is I'm still able to do this minimally invasively. So I use navigation. So I do a CT scan in the OR that shows me in real time what my instruments are aiming at relative to a CT scan of someone's spine. And then I can put the screws in through 4 tiny incisions about the size of my pinky. And then I use the same tube, that 2-centimeter incision, to put this cage in. And just as a point of comparison, so I'm able to do all of it through an incision that can fit that tube in, versus if you were doing it in the traditional open method, you have to dissect down along both sides and then remove all of that muscle and soft tissue way out to the sides. This can be very painful. This is still a little painful, but certainly far less invasive than having to open everything up. So as I was kind of touching on before, one of the reasons that I might have to do this is if sometimes those bones will slip forward relative to one another. And my approach is, if it's slipped forward but it's stable, then I'll still try to do a decompression and avoid the fusion. But if that bone is slipped forward and then I get bending x-rays and it shows that it keeps moving around, then I have to do the fusion to prevent the symptoms from coming back. Or if there's narrowing in that nerve channel, the only really way to get it is with the fusion. So then kind of segueing into physical therapy. So just looking at some restrictions and post-op protocols. So if someone's coming with cervical radiculopathy, so some of the things that physical therapists can do would be traction, and that's actually trying to pull the head away from the shoulders to open up the space. And that's really helpful, one, because it helps you feel better, and two, that's really useful information to me to help kind of confirm that it isn't the symptoms that a patient is having is in fact coming from pressure on that nerve. There's deep neck muscle strengthening exercises and scapular strengthening exercises, working on posture. I don't know if any of the therapists in the room have any other things they want to add to things you guys try to do with someone who shows up with cervical radiculopathy. Yeah. So And then, so pretty similar for lumbar radiculopathy or pressure on a nerve in the lower back. There's core strengthening. So I think it's really important that, the stronger that your core is and the less weight you have on your spine, the more you're going to be protecting your spine and preventing it from having problems. Hamstring flexibility is a big one. Every time I check someone to do a straight leg raise test in the office, it's amazing how many people can't, their leg is stuck like this and it can barely go 20 degrees up. So if you have hamstrings that are that tight, it's going to pull your pelvis forward and pull everything out of alignment. And put some abnormal forces on your spine. So that, working on flexibility is another huge part of trying to protect the spine. And then same thing, the traction beds where you're going to go inverted and really distract the spine and open up the space for those nerves can help people feel better. If I'm doing a discectomy, so sometimes if somebody has a herniated disc, I'll go in and you make a little window through the bone and you remove that piece of disc. For those, I try to limit those patients a little bit more because the concern is that that disc can re-herniate and then we're back to square one. You did this big surgery to take the pressure off the nerve and then they go and bend over and pick something up and it re-herniates and puts pressure back on the nerve. So I protect these patients a little bit more and try to avoid the bending, twisting, lifting for 6 weeks. I am fine with people walking though, same day of surgery, day after surgery. At 2 weeks, you're okay to get on a stationary bike or elliptical because there's no impact or pounding. And then for the kind of more aggressive activities such as like swinging a club or a bat, those I try to wait about 3 months for, again, just to avoid having that disc re-herniate. If I'm just doing a decompression though, you're still trying to minimize some of that bending, twisting, lifting, but I really start to let them increase their activities after 2 weeks and let kind of pain just guide them in terms of what they're able to do and not do. And that's for both the decompression and the fusion as well. For cervical, again, I think walking is huge. I want my patients up and walking ideally the same day unless the surgery ended, late in the afternoon or at night. But trying to get, people up and moving around and back to their activities. I think the image in the past of spine surgery was you'd be admitted to the hospital for multiple weeks, laying in the bed, a really painful recovery. And I think one of the benefits of the minimally invasive approach is to get people back to their activities as soon as possible. I mean, that's why patients are coming to me to get rid of their pain and get back to doing what they love doing. So I certainly try to help expedite that. And then I do have patients avoid kind of heavy lifting. You just don't want to put a ton of force through your neck after we did a big surgery. If I'm doing something from the back, then those incisions, you also, again, have to protect more. So you really want to avoid having a patient kind of come forward or pull their arms apart to just avoid any tension on the back of the neck. So that's my lovely wife and 2 daughters. So thanks so much for taking the time to listen to me. Do you guys have any questions about anything? Yeah.
The first slide you showed a compression and the fluid was missing in one part of the cervical. How does it, right there, so how does that fluid get replaced where you see it's pressed out?
Yeah, so this fluid, this is the cerebrospinal fluid, and it flows all the way it circles all around your brain, and it flows down all the way along the spinal cord and then down to the bottom of the lumbar spine and back up. So your body automatically generates that fluid, and essentially what's happening here is it's just getting squeezed so tightly that all that fluid is being squished out of this section. But once I go in and remove, you either come from the front and remove these discs or more likely come from the back and hinge this all open. Once you recreate the space, it's like a water balloon that just kind of reinflates, and you can actually see that in surgery. So when I get in there and I start operating, everything is totally squished down and putting pressure on the dura is the membrane that holds that fluid. And then by the time you're done, it should have totally inflated back up. And when it's completely decompressed, there's a little bit of pulsations coming through that region. And so you can actually see this really nice pulsing of the fluid contained in that the dura, showing you that you really adequately decompressed what you were working on.
So now that's through a surgical procedure. So would there be a procedure that you could do exercising that area, like through physical therapy, that would open it up?
If you have bone growth that's putting pressure on that area with the fluid, then not really. In my mind, the exercises and stuff are more to help with the symptoms, because if we can get your symptoms to a manageable level without surgery, that's a huge win. but there's no real way to open the space back up without going in and surgically doing it. If there's a disc herniation, your immune system actually resorbs the disc that's in a place where it shouldn't be. It doesn't always do that though. So that's why if somebody has a disc herniation and it's been present for a while or starts causing progressive symptoms, then you kind of say, okay, that we let the immune system have a try at it. Now it's my turn to have a try at it to go in and remove that disc. Yeah.
Is, trying to find the words.
Yeah.
Phrases. When you're first seeing a patient, what is like the most common red flag you see to help you distinguish between myelopathy versus radiculopathy?
Yeah. So in my mind, for myelopathy, if someone is talking about hand clumsiness, so I always try to really focus on, and even if they're showing up with like back pain, I still ask everybody because I don't want to miss it. You know, are things like jewelry and buttons harder for you? Do you feel like you're dropping things more often? Like, do you feel like you're falling, or is your balance a little bit off? And then there's a couple reflexes. So the easiest one to test is, it's called a Hoffman's reflex. But so you flick someone's kind of the last digit of their middle finger, and if the rest of the hand is flexing, then that's an abnormal reflex. Or if you push up rapidly on someone's foot and the foot repeatedly puts, normally you should only have like 2 beats afterwards. If it's doing a repeated pushing down with your foot, then all of those signs are saying, hey, there might be pressure on the spinal cord. And then if I pick up on any of those things, so either they're telling me I'm having difficulty with my hands and balance, or I'm picking up on abnormal reflexes, I order an MRI of their cervical spine right away. Because I want to make sure, if it is in fact pressure on the cord, that we identify and diagnose it and treat it right away.
So
Yeah.
if somebody like they immediately come in to see you and like the symptoms only lasted like a couple of days, like it hasn't been a long time, will like Hoffman's and the clonus, would that be present like immediately?
So myelopathy is usually, if it's there, it's going to be there and stable, and it's just going to progressively get worse. So usually if somebody is showing up and their symptoms started 4 days ago, that's going to be more likely to be radiculopathy, of like pain shooting down the arm, or maybe they herniated a disc in their neck and now their biceps is weak, or they have numbness in the same kind of distribution. So usually someone who shows up and it's more that acute, hey, things started 4 days ago, that's radiculopathy for the most part. Myelopathy, almost all those patients are showing up, they're like, hey, this has been kind of like happening for years, but I noticed recently it's been getting worse. That's the more typical history of somebody with myelopathy showing up. Yeah, of course.
So if a patient had an ACDF and the patient's symptoms are not getting any better, so is there any other approach if the ACDF has gone wrong to correct it?
Yeah. So let's say, I just started here, or relatively recently moved to the area. So I'm still sometimes seeing patients that other spine surgeons have operated on, and they've got a history of an ACDF and they're still having issues. So I just treat them as kind of like a brand new patient and start everything again from the beginning. So I get x-rays and an MRI of their neck. And then you want to look at, okay, is it the level with the ACDF causing problems? Or is there a level above or below that's causing problems? So last Friday, I had somebody that had C3 to 6 fused, and then many years ago, and then all of a sudden started having the myelopathy symptoms coming back. Their hands are getting clumsy, their balance was off. So got a new x-ray, MRI. The levels that were operated on looked fine, but the level below had totally worn out. There was a disc herniation and bone growth, all putting now, again, pressure on the spinal cord. So for that one, I just then extended the fusion down 1 level. But if let's say I got the imaging and it showed, the area with the ACDF is still causing problems. If it looks like everything was done correctly from the front, you still have the ability to come in from the back and you can open up, take pressure off of the spinal cord from the back. But usually if you get a good fusion, those bone spurs will actually kind of recede and become a little bit smaller, and should ideally then take the pressure off the cord.
So currently I have this patient who underwent an ACDF, but then her doctor had to leave, and then she went back again, and the new surgeon did the posterior approach, and she had the whole thing fixed again. But now, initially she had the symptoms on the right side. Now she started to develop some tingling on her upper trap muscles, and
Okay.
her right hand weakness is still not completely recovered yet.
Okay.
So is it a concern that she should be going back to the doctor?
If it's getting worse, then absolutely. For something like that, you might not always get 100% recovery, and that's something that I, unfortunately talk with all my patients about. Is like, we're going in to take the pressure off the nerve, but if someone shows up and they're like, hey, my right arm has been weak for 5 years, it's going to be a whole lot harder to get that nerve to come back to life and wake back up, and it might, if it does, that might take up to a year to see kind of the maximum improvement from that nerve, just because nerves are very slow at healing. But that's where, it's really important to set appropriate expectations before surgery and make sure that the patient understands of like, we're going in with the hopes that this is going to get better, but especially if it's been present for a very long time, it is always possible that it doesn't fully go away or kind of stays stable. Yeah.
For radiculopathy, there's a PT intervention like nerve gliding.
Sure.
Or
yeah.
nerve flossing. Do you know about the evidence with that?
It's not something that I have done or studied or looked too closely at, but I certainly have heard about it, and I've spoken with therapists who said that they've had good luck with it, and I think like it makes sense if you're able to kind of get that nerve moving, and free some space up for it. Then, in my mind, it's one of those things where it's pretty low risk, right? So if you're able to do some therapy and it gets somebody 50% better or helps them with their symptoms, but very little risk of harm, versus me going in and using power tools and biting instruments next to someone's spinal cord and nerves, the risks are significantly higher. So I always love to know that someone has tried everything possible before saying, okay, we've exhausted everything that could have helped you. Now it's pretty clear that we do have to at least consider moving forward with surgery. So that's where I think the more modalities you can try to employ, the better. Yeah.
I guess one of the things that sometimes we see patients is they'll have an MRI and they'll have multiple disc herniations, and they may not have symptoms associated with it. How much do you rely on seeing that there's some sort of mechanical impingement on the nerve versus the symptoms to determine how you're going to do the surgery? I guess also sort of along with that is how much is radiculopathy a mechanical impingement versus more of an inflammation type situation?
Yeah, so that's an excellent question, because patients they come to the office and they're like, doc, I've got disc herniations at 6 levels or 7 levels, and I'm always like, okay, we'll go through everything. So one of the first things I tell everybody is, if you were to get an MRI of everybody off the streets, I would be more surprised if you found an MRI that was completely normal than one that found, there's a couple of disc herniations or a little bit of bony overgrowth or some degenerative changes, just because that's the natural history, is that spines wear out as we have more and more birthdays. So the size, location, and kind of duration, I guess I'll say, like, of the disc herniation is what I look at the most. So somebody might have, let me see if I can find a lumbar MRI. Somebody might have, so let's say there's like tiny little bulges at each of those levels, but it's not putting pressure anywhere on the nerves, then not to be too blunt, but I don't care. It's kind of like a little disc bulge that's not touching a nerve. You're never going to convince me to go anywhere near it operatively, because I don't think it's causing any of the symptoms. Versus if you have a disc that's herniated just out to the side and squeezing that nerve kind of right there in the corner, it doesn't actually have to be that big of a disc herniation. As long as it's hitting that nerve perfectly or kind of taking up the space that that nerve wants to be at, then it can cause severe symptoms and weakness, and then you might consider kind of your more interventions to take care of it. In terms of the mechanical versus inflammation, that's where the steroid injections are really helpful. So if it's just like kind of some temporary inflammation or something going on, and if you put steroid right here and it cools everything down and stays kind of now not inflamed, then that's great. That's really helpful. And I have patients that get one steroid injection and feel phenomenal for years plus. If it's a mechanical thing, then that steroid is going to wear off usually pretty quickly. So I have a lot of other patients that will come and they're like, yeah, I felt, maybe 50% better for a day or two, and then it totally wore off. So in my mind, that's still, I feel bad that the injection didn't last longer, but it's still very useful information because we've confirmed that the pain is in fact coming from the spot I'm looking at. Because, to one of the other parts of your question, somebody might show up and they might have pathology or disease at multiple levels throughout their lumbar spine. I try to really just focus and target on what do I think is the one, maybe two things that's causing all of your symptoms, as opposed to saying, oh, we're just going to get in there and open up everything and treat everything and do this huge surgery. I try to really hone in on what is the one thing that I think is kind of going on and fix that and leave the rest alone, because a lot of times you have these degenerative changes that aren't causing symptoms, so there's no need to expose someone to more surgery to put them at more risk when you can fix it with a narrower focus. Did I cover everything?
Yeah.
Okay.
Those are very thorough answer.
In that scenario where the quote-unquote steroid only lasted for a couple of days,
Mm-hmm.
And you got that information, what would be your next steps?
So that depends on what the patient is kind of like going through. So if somebody is in 10 out of 10 pain, they can't do anything that they want to do, they've got pretty weakness, 4 out of 5. Usually once it hits 3 out of 5, then I'm pushing a little bit more for we need to go in and open this up. But that's where I have that discussion with the patient of like, okay, we've kind of confirmed that the pain is coming from that spot that we put the medicine at. You have the option to certainly try another steroid injection and go in and see if maybe the second one or the kind of cumulative effect helps your symptoms more. Or at that point, I'm then more open to saying we can talk about surgery to go in and take the pressure off the nerve. Because usually by then they've done physical therapy, they've tried an injection, it temporarily worked and then wore off. And then by that point, they're usually pretty frustrated with their symptoms and ready to take on something a little bit more bigger in the form of surgery to go in and take the pressure off. Yeah.
How long do your minimally invasive surgeries last? Have seen a lot of patients that have had the more like maximum open, all that goodies, and they're like, this has lasted me maybe 20 years, and then they come back with the exact same symptoms that they had previously and trying to go for more of the conservative approach.
Yeah, I mean, the whole point of the minimally invasive is that you should have the exact same long-term outcomes as an open procedure, with just way less pain, insult to the soft tissue, and everything in the short term. I think the other benefit is when you're doing, let me see if I can find this one. So when you're doing this open, there's a bunch of ligaments that connect all of those, the spinous processes or the bumps in the back of your spine. There's a ton of ligaments back there, and there's joint capsules and levels above and below. And if you're doing an open surgery, you're at much greater risk of disrupting all of that soft tissue that helps protect the spine, versus when I'm just coming in here and then removing this bone and this bone, I'm nowhere near the ligaments in the back here. So I think you're far less likely to get breakdown at the levels above and below. So theoretically, it actually might last longer than the open stuff, just because in an open surgery, you might get into more of the soft tissues and disrupt other things that are going on to help the spine.
To follow up then, would you go back into with a patient who has had that open and try to do a revision with the minimally?
I've done, yeah. So like 2 or 3 weeks ago, I had a patient who had an open discectomy like 10 years before. And then I did a revision discectomy, and I still just did it minimally invasively through a tube.
And with a replacement or no?
This was just a lumbar disc herniation that it had re-herniated a long time down the road. And so I went in and was still able to just get the herniated disc fragment out. And he felt much better. I mean, it was like a 3-inch piece of disc. It was the biggest disc herniation I've ever seen. And he woke up feeling amazing.
That's success.
Yeah. Yeah.
Well,
Yeah. Yeah, no, it's great.
How would you? So I'm a student for PT,
Okay.
and I deal with a lot of people that I feel like just need to go in for surgery
Yeah.
or try the injections to help with their inflammation, and they just want to stick with PT. And
Yeah.
they're not seeing any progress.
Yeah.
How would you word like trying to convince them to at least go see?
Yeah, I think the way I navigate that discussion is saying like it's always worth meeting the person and having that talk, right? To just see like what do they think are gonna like, do they think you could benefit from it, or do they think no, you really should stick with PT? There's no risk, right? You're not signing up for surgery, you're not signing up for an injection, you're not committing yourself to anything. It's more just that you're able to then have that discussion with a slightly different, right? Because I'll bring a different perspective to the table than a physical therapist would, and also one of the main things that I try to do in my office visits is just educate the patient. The amount of times that I'll like have a patient come in that's maybe seen 2 or 3 spine surgeons before or seen a couple doctors, and they still have no idea what's going on. So if nothing else other than to just learn more about what is going on in your spine and what are the potential options so you can at least consider them in the future. Because I really try to take the time to explain, okay, so this is what I found on your exam. This is your MRI, and I take a long time to explain to them what I'm seeing on the MRI, what kind of matches up with the MRI and what their exam and history are telling me. And then what's the full range of treatment options, just so that, again, they kind of now have all of that information, and then they can go home and think about it and talk to their family and talk to their therapist again. But really just, there's no harm in the discussion and trying to educate yourself more about what is actually going on.
I have an extrusion at L4 and L5.
Sure.
So I was basically crippled for about 3 months.
Sorry to hear that.
I got an epidural. It was like magic for a month.
Okay.
Then the pain's back now.
Okay.
So Dr. Cronin at Mass General, I visited him. He says he recommends a fusion, but it's a total disaster. I read his notes, and you're 3 months, you're in bad shape, and then you start getting better. So I did maybe 100 hours of research online because I was sitting down and can't walk. So I called David Disworth in California. I saw him in 1990 for a partial discectomy. He said, we operate 3 o'clock in the afternoon, and you go on a plane 6 o'clock at night. Total recovery. He invented special tools to do it. But I'm on Medicare, so he wants 35 grand cash up front. So, but I know he did it before. Go dancing after the operation.
Yeah.
He knows how. He doesn't have to cut all the bone out. He knows how to sneak in there and do whatever he does. So then, these all have good reports online. Then I found one in Florida. He does ultrasonic surgery. And again, you go dancing after the surgery. No recovery. You don't stay in the hospital. Then another institute there. These are big operations. I'm not talking one doctor. He does laser. And same thing with him. He'll go in and no big recovery. You go home the same day. And then the doctor that wanted to operate at Mass General, after he tells me the total disaster, what he's going to do, walking out the door, he says, the macrophages in your body could cure it, and you'll be okay. And then an anesthesiologist, separate, after he went over all the bad things, he threw in a postscript. So the macrophages in your body, as bad as it is, it could take a few months, but they could cure you because they're eating away at the damage that's there. So that's it. So what do you know about those alternatives? The ultrasonic, the laser, and ozone therapy too.
Yeah, so the ultrasound, laser, there's not the greatest of data and science to support those outcomes. I don't do those, and I think there's a reason why I don't do those. I don't think that they're that effective. I'm sure there are people that have had those procedures done and feel better afterwards. But I think if you have bone and overgrown ligament or disc or something putting pressure on a nerve, an ultrasound or a laser isn't going to make that go away. You need to go in and physically remove that stuff that's putting the pressure on the nerve.
Well, the fusion that you do, how long is the recovery on that?
Yeah, so for the minimally invasive fusion, usually spend like one night in the hospital, and then the first 3 weeks are a little bit more variable. You know, you'll definitely have some back pain. I'm doing a big spine surgery on you, but people can start to feel better, at least with the leg pain, sometimes pretty quickly afterwards. I want you up and walking around and moving around and doing stuff, and then kind of gradually increasing your activities. There are certainly some patients who can have pain for, you know, the 6 to 8 weeks or longer, but usually the recovery is you know, the first 3 weeks is the more variable part, and then after that you start progressing and doing better.
If you wanted to, could you do the laser? Or is that
No.
just-
I wouldn't do that.
No, you wouldn't, but you could if you wanted to. Is there certain
As-
capabilities or magic that they have that you don't have? Because they claim they got tools that no one else has.
Yeah, I don't know. In my mind, usually if there's something that sounds too good to be true, often it is, you know? And if there's only one place in the United States that's doing it, I've worked with like some very brilliant spine surgeons that are always looking for what is the best thing that, you know, the least invasive, best thing we can do. And if every mentor I've ever worked with and most other places aren't doing it, usually you're going to be a little bit hesitant about like, wait, then maybe this is too good to be true. It's not something I've ever been trained on or had much exposure to. I've just obviously like know some of the literature on it.
Well, the one that does the laser, he has online maybe 100 operations that he's doing live.
That sounds concerning too.
What?
I said that sounds concerning. I wouldn't, I don't know. I wouldn't want to put my patients online and, you know, it's
You don't know who they are. You just see the hole in the back.
yeah. Yeah, I don't know. I also look at, you know, if I'm operating on someone's spine, I want my pure focus to be on the procedure and not some marketing.
What do you think of the macrophages making it go away?
Yeah, I think that's just one way of describing the immune system potentially resorbing some of that disc herniation. But I obviously haven't seen your imaging, so I don't know if it's a disc or bone or ligament. If it's bone or ligament, then macrophages aren't really going to resorb that or eat that away.
Well, they said it might, so maybe it's
Yeah.
a situation. They have the MRI that might do it.
Yeah.
Well, we went to saw a hot doctor the other day, and I told him about my back, and he said try. He went to that. He said try marijuana. So we got these candies. They're like jelly. So I took quadruple the dose last night. Now, this has never happened. I slept 7 hours straight. That never happened. I sleep usually 3 or 4 hours. It was honest, and I felt great. So, yeah,
There you go.
See, you might want to give that a shot. Yeah, I was shocked. I collapsed on the couch without even knowing. I went full asleep. It took 2 hours for it to kick in.
Yeah.
And then I woke up 7 hours later. That hasn't happened.
More sleep than I got.
Well, what?
There's more sleep than I got.
I don't know. It was weird.
Yeah.
That's what kids will do.
Yeah.
I guess in my brain sometimes, you know, as a physical therapist, I've been doing it for 20 years or so, is that open surgeries in my brain just tended not to have great outcomes. I guess, what have you seen with the minimally invasive in terms of your experience with people being able to dance afterwards, I guess, people like having better outcomes?
Yeah, I think open surgery done well, you still get great outcomes. A lot of my mentors performed open surgery and took phenomenal care of patients. I always was a big believer in protecting the soft tissue, doing the least amount of, you know, surgical insult to the patient as possible, and that's why I picked where I went to do my specialty training. And I definitely feel like I've had patients that have said, oh my gosh, I have been in pain for 10 years. There were so many things that I couldn't do. And now I wake up and that surgery was life-changing. I can go back and do all the things. Like, I'm walking better. I've had people pull me aside and be like, what'd you do? You're like walking normally now. And so to me, that's like the greatest compliment that I can receive, is that they're getting back to their activities that they want to do, and, you know, without pain, and the motor strength, the muscle strength has returned, and, you know, they're back to living their lives. So,
When you do the fusion, say you do 100 out of the 100, are they all happy, or do you have problems?
I mean, it's spine surgery, so there's always going to be complications and risk of issues, and it's nothing. And again, anybody who says I have 100% success rate, they're lying, right? That's just, it's impossible to, even if you do the surgery perfectly, the nerves can get stretched a little bit when you restore the normal height, and there's always things that can go wrong. So certainly nothing is 100%, but I would say I only offer somebody a surgery if I'm convinced that I think it's going to help them, right? If I don't think it's going to help them, and even if my hardest office visits are the patients that come in that have really severe pain, but their imaging doesn't look that, the narrowing is just not, it's not there. It's not enough to justify exposing them to the surgery. I think if you operate on all those patients that something's not matching up, you're going to have bad outcomes because they probably shouldn't have had surgery to begin with, versus if the symptoms match up and the imaging matches up and I really feel like I can make a meaningful impact and make their lives better, then I offer surgery, and those patients do really well.
Do you do your surgery at St. V's and also the surgical center, or just all?
Right now, I'm purely at St. V's. Yeah. At some point, I might start doing some cases over the surgery center, but there's so many specific instruments that it turns out aren't that cheap, that it's harder to then try to setting up another place to be able to do it. Especially with the minimally invasive stuff, I don't think anybody else here is doing it. So there's all of the tubes and dilators and the special kind of bayoneted instruments so that you can see what you're doing, are currently only available there.
So with spinal stenosis, it's the CSF that's causing the pressure on the spine.
No. So the CSF should be there normally. That coats all of the nerves, and if I see the CSF, then that means, okay, that level is pretty good. The stenosis is usually caused by a combination of three things. You usually have a little bit of disc bulging out, you have those bones overgrown, and then there's a ligament in the back that connects those bones, and that also overgrows. So similar, if you get arthritis in your knee, you'll get some bone spurs, and the bone actually kind of grows a bit. It's not as big of a problem in the knee because there's room for it to go. The problem is when you get arthritis or the degenerative changes or stenosis in your back, and those bones start growing, there's nerves right there, and so then it immediately causes a problem by putting pressure on the nerves.
Other than ibuprofen and gabapentin, are there any other pain relievers that might be done?
So there's, depending on obviously your medical history, but there's always NSAID, so Motrin, Aleve, meloxicam, different options there. Lyrica instead of gabapentin is another option. But there's usually a kind of a bit of a variety, some muscle relaxers. I don't think narcotics are a bad idea for spinal stenosis. It's not a healthy long-term option. But
With the spine fusion you do, sorry, I'm asking a bunch
no,
of
you're
questions.
fine.
How much range of motion does the patient lose?
So that's a great question. So in the neck, they've done studies where if you fuse up to 3 levels, they put a football helmet with motion sensors on it before and after, and they found that even at 3 levels, patients actually gained range of motion. And then same with in the back, if you take a totally healthy spine and start removing motion segments, yes, you're going to limit a patient's motion. If I'm operating and doing a fusion, it's usually because the disc has completely collapsed and then now slid forward. And these bones, I get x-rays of everybody bending forward and backwards. Those bones aren't moving at all. And if anything, they're actually causing you pain. So patients are always like, why did you tortured me and made me get those bending x-rays? And then I can say well, one, it's really helpful information to see if there's increased instability. But 2, I'm able to then point out you don't have much range of motion right now because when you move, it causes so much pain. If you take away that segment that 1 isn't even moving normally and 2 is actually causing pain when they move, they're able to bend so much more easily and functionally gain range of motion back. Versus if you took a healthy spine and just started putting screws, then yes, of course, you're going to take away range of motion. But
if you have neck and spine, is it 2
separate surgeries?
So it might so cervical, neck, thoracic, and then lumbar spine. They're all part of the spine. So what are you asking if you have neck and lower back?
Right. I know I have lower back, neck. I'm thinking I do.
Okay. The neck, depending on what it is, almost always takes priority, especially if it's that myelopathy one. And then if it's just pressure on the nerves at the two levels, then you can kind of say which one is bothering a patient more or causing more significant symptoms. But yeah, usually I've done both at the same time, but it was only because a patient had horrible myelopathy and a complete foot drop on the presenting at the same time. And so I couldn't wait to fix the problem in the lower back because their motor function had gone to zero. And if you leave that, then that nerve will die and not come back. But in the absence of somebody coming with two totally critical, urgent problems, you really want to stage them so that you give the patient time to recover from one surgery before you do a second. Yeah. Okay.